Hello, everyone. You have studied M receptor antagonist. So, in your mind, do you still remember those drug names like atropine, anisotropium, scopolamine, ipratropium bromide, tropicamide, pyrazapine, propanseline? Do you know those drugs? Okay, maybe you know. Now, let's study the new content, N receptor blockers. N receptor include two subtypes, an N receptor and an M receptor. So that's why these agents also subdivided into two families, an N receptor blockers and an M receptor blockers. N receptor blockers, they can block the action of acetylcholine and the similar agonist at the N receptor within both parasympathetic and the sympathetic autonomic ganglia. Because they can activate both parasympathetic and sympathetic postganglionic fibers, so they often induce many pharmacological effects. So has no higher selectivity to the effectors. So nowadays they have been abandoned for clinical use, but they are important and useful in pharmacological and physiological research. Actually, these two agents, mecobalamin and trimethophan, in the past they were used in the treatment of hypertension. Actually, because nowadays there are so many antihypertensive drugs, you will study those. So they are totally replaced by the other agents. But actually, nowadays, mecobalamin are still used in the abstinence treatment of smokers. But it also is relatively less used than an M receptor blockers. So an M receptor blockers, they mainly act on the skeletal muscles. So an M receptor is blocked by these agents, induce a skeletal muscle totally relaxed. So they are caused by skeletal muscle relaxant. In practice, the blockade of end plate function is accomplished by two mechanisms, depolarization or non-depolarization. So these drugs, based on these two different mechanisms, also subdivided into two groups, depolarizing muscular relaxant and non-depolarizing muscular relaxant. Now look at this figure. How about this mechanism? An M receptor in the muscular cells, it can be bound by acetylcholine. Once this complex of this acetylcholine neurotransmitter and receptor complex formed, it can induce a depolarization followed by repolarization. And then the membrane potential recover to the resting potential, and then they can accept the new stimulants like acetylcholine neurotransmitter to induce new stimulation on the skeletal muscle contraction. This is the effect caused by neurotransmitter acetylcholine. There are some drugs like non-depolarizing muscular relaxant. They also can bind to these receptors. But because, acetylcholine work as a neurotransmitter, they often can be metabolized by cholinesterase very fast. So they can be activated rapidly. But these non-depolarizing muscular relaxant, these agents are more resistant to degradation by acetylcholinesterase. and can induce more persistently depolarization on the muscular fibers. So look at the depolarization. It's like this. It is followed by a slower repolarization. You know, the membrane potential cannot recover to the resting potential. Do you still remember refractory period? You know, this persistent, relatively longer repolarization make this membrane potential is relatively higher level. So it prolonged the refractory period for these muscular cells. So during this period, you know, these muscular cells lose response to the new stimulants like acetylcholine. Do you understand? So, you know, it can induce skeletal muscle relaxed. But you know, it still induces a new depolarization. So at the beginning of this drug in use, it also induces a initial contraction of the skeletal muscle, but followed by skeletal muscle relaxation. Understand? You know, so that's why this drug caused by depolarizing muscular relaxant. There are some other agents also has affinity to bind to the receptors, but compared with acetylcholine or non-depolarizing muscular relaxants, they has no any intrinsic activity. Alpha is 0, so they are competitive antagonists of an NAM receptor. Remember, antagonists include competitive and non-competitive. These non-depolarizing muscular relaxants, they are competitive and receptor antagonists. Just bind to this receptor and occupy this receptor. They cannot induce depolarization, so there is no contraction of the muscular cells. Understand? So just induce muscular relaxation. This is the mechanism of non-depolarizing muscular relaxants action. Okay, so based on this mechanism, can you guys, what are the difference of the pharmacological effect between these two group drugs? And how about their clinical uses? Let's go on. Maybe you are curious about the pharmacological effects and clinical uses of skeletal muscle relaxants. Let's go on studying. Depolarizing muscular relaxants. Nowadays, succinylcholine is only one available agent in this group. Just now I introduced this drug can induce an excessive depolarization. So they induce a lasting depolarization and cause no reaction of an NAM receptor to acetylcholine, induce a skeletal muscle relaxation. Actually, because of this non-depolarizing mechanism, this action includes two phases. Phase 1, it caused by persistent depolarization. You know, it prolonged the period of effective refractory period. During this period, the muscular cells lose ability to respond to the neurotransmitters or any other agonist. So it just induced this persistent depolarization. You know, during this depolarization, these agents cause the opening of the sodium channel associated with the nicotinic receptors. Then it results in depolarization and a transient twitching of the muscle. You know, this is fasciculation caused by fasciculation. It can cause fasciculation at the beginning of the use of this drug. Phase 2, it caused by desensitization of an NM receptor to acetylcholine. During this effective refractory period, because of this, membrane potential is too high. So during this period, lose ability to respond to the other stimulants. So this is desensitization. So during this period, this skeletal muscle is relaxed. So continued binding of the depolarizing agent renders the receptor incapable of transmitting further impulse. With time, continuous depolarization gives way to gradual repolarization as the sodium channel closes or is blocked. So this agent causes a resistance to depolarization, phase 2, and flaccid paralysis. Because of this mechanism, this drug, the characteristic of its action is it induces initially transient muscle vasculation because of this depolarization, followed by flaccid paralysis, phase 2. But this drug, relaxation of skeletal muscle, this effect has a rapid tolerance, tachyphylaxis. Has a rapid tolerance after the repeated use. And anticholinesterase agents cannot reverse its relaxation because this relaxation of skeletal muscle is not caused by competition to bind to the receptor. So cholinesterase agents, these drugs can increase the concentration of acetylcholine neurotransmitter. In another group, non-depolarizing muscular relaxants, these anticholinesterase agents can reverse their relaxation. This is their difference. And this drugs has no blockade of ganglia. Just now I mentioned, succinylcholine is the only depolarizing muscular blocking drug still available in clinics. Okay. This drug, following the intravenous administration of succinylcholine, paralysis develops within 1 minute. So this relaxation of skeletal muscle, this effect onset very rapidly. Because this drug also can be metabolized very soon by this pseudocholinesterase in the plasma or liver. So the duration of muscular blockade is usually 5 to 10 minutes. So this muscular relaxation, this effect just lasts for several minutes. It's very short. But do you still remember idiosyncratic reaction? Because of some genetic difference, a few people are lack of this and them. So the metabolism of this succinylcholine in their body is very, very slow. So this effect will last for long time, different from the other majority populations. Understand? Remember that? Okay. Because of rapid, complete, and predictable paralysis with a spontaneous recovery in about 5 minutes, this drug, once administered, its action on-site very fast, within 1 minute is enough, and then metabolized by pseudocholinesterase very rapidly. So this skeletal muscle relaxation, this effect just lasts for several minutes, recover the function of the skeletal muscle spontaneously. So this is predictable, So this drug usually used to facilitate intubation with an endotracheal tube, laryngoscopy, bronchoscopy, and esophagoscopy. Understand? You know, this is muscular relaxants. Try to understand what conditions the skeletal muscle should be relaxed, during some medical operation. Because of this rapid and spontaneous recover of this action, so during this intubation, it is useful. It is also useful an adjuvant in surgical anesthesia to obtain relaxation of the skeletal muscle to facilitate operation. Now, look at. Of course, because this drug, it also induces a depolarization. So usually because of this drug induces some adverse reactions like post-operation myalgia, because it has a muscular tension fasciculation at the beginning. And maybe act on the intercostal muscles, induce respiratory paralysis, even apnea. Hyperkalemia, especially the patients with burn, malignant tumor, or renal insufficiency, or the patients with cerebral vascular accident. These patients has relatively higher risk of hyperkalemia. So for this disease, actually, they can be considered as contraindication for succinylcholine. Try to avoid hyperkalemia occur. Actually, potassium ions, their concentration should stay in a normal state. Once some patients has this hyperkalemia, it often induces like arrhythmias. It's relatively dangerous. And some patients, because this drug induces a relatively rapid contraction of extravascular muscles, so in some patients it can increase intraocular pressure. Yeah, some patients maybe has intragastric pressure. And only a few patients maybe also have hypersemia. This maybe it is related to heredity. Another group of skeletal muscles is non-depolarizing non-muscular relaxants. Just now I also explained it is competitive antagonist of NM receptor like tubocurarine. Tubocurarine, this drug, it is used to paralyze an animal by native South America hunters in Amazon region. Yeah. So actually, because they can induce skeletal muscle relaxation in the animals, so they can get food from the animals. And the mesocurine and methylchloride, these drugs, like tubocurarine, they can act predominantly on the NM receptor side to compete with acetylcholine and prevent access of the neurotransmitter to its receptor and prevent depolarization caused by neurotransmitter. So this is competitive muscular relaxants. Because they has no intrinsic activity, they cannot induce depolarization. So they also caused by non-depolarizing muscular relaxants. Because this is competitive antagonist, so cholinesterase inhibitor can reverse its blockade and relaxation. Remember, just now I also mentioned this. Cholinesterase inhibitors, because they can inhibit cholinesterase metabolism, cholinesterase, it can inhibit cholinesterase to metabolize the acetylcholine neurotransmitter. So increase the concentration of acetylcholine. Acetylcholine can bind to the NM receptor in the skeletal muscle, compete to bind to that receptors. So acetylcholine can antagonize the effect of these agents. Understand? So it can reverse its blockade and relaxation. Actually, these drugs, when they are used, not all muscles are equally sensitive to blockade by competitive agents. Usually, the rapid contracting muscles are first blocked, like the muscles in face or eyes, and then followed by fingers, limbs, neck, and junk muscles, and then further relax intercostal muscles. The diaphragm is the last one. The recovery of the skeletal muscle, it is in reverse manner like this, in reverse manner to recover. So these drugs usually can be administered intravenously or occasionally intramuscularly, but not oral administration. In the clinical practice, the choice of an agent in this group depends on the desired onset and the duration of the muscle relaxation. So it's different from succinylcholine. This muscular relaxation is relatively longer. So they can use it in surgery, work as an adjuvant, in surgical anesthesia. Because use of this skeletal muscle relaxation, it requires a relatively less dosage of anesthetics. So neuromuscular blocking agents have significantly increased the safety of anesthesia because less anesthetic is required to produce muscle relaxation. This result allows the patients to recover quickly and completely after surgery. Okay, that's all for this part about N receptor blockers. So there are several questions for you. Can you fill in this blank? Okay. Now, you have studied agonist and antagonist for M receptor and N receptors. These are the drugs classification. Okay, this figure maybe also is helpful for your study. Okay, let's go on study. Because next chapter, you will study adrenoreceptor agonist and then followed by adrenoreceptor antagonist. So before you studied those drugs, you still first go over this receptor distribution and their functions. Now, so in this class, I also introduce this in detail. You have studied adrenoreceptor mainly include alpha and beta receptor, and alpha receptor also subdivided into alpha 1 and alpha 2. Alpha 1 receptor, it is usually located in postsynaptic membrane, on the effector cells, and mainly resides in skeletal, smooth muscle. Here it means smooth muscle. I usually use SKM means skeletal muscle. This means smooth muscle. In our body, there are so many smooth muscles, like blood vessels, like pupillary dilator, or some sphincters. Once this alpha-1 receptor is activated by epinephrine or non-epinephrine, it often induces contraction of smooth muscle. Understand? Especially blood vessels. In the body, there are so many different tissues and organs. Actually, this alpha-1 receptor in the different tissue or organs, the blood vessels contain different density of alpha-1 receptor, different density. Once this alpha-1 is activated by agonist, because of the different density of this distribution of alpha-1 receptor in different tissues, actually the blood vessels, contraction, they also are different. Now, look at this. Usually, the blood vessels in these tissues, alpha-1 is the highest. It's the alpha-1 in the blood vessels in cutaneous and muscle membrane vessels. Alpha-1 here, it is the most compared with other tissues, blood vessels. Blood vessels in the cutaneous and mucous membrane tissue, it is the highest, it's the most. And in the visceral organs, splanchnic, especially the kidney, the blood vessels in kidney, the alpha-1 receptor, its density is higher than the other tissues. And then liver, mesentery, skeletal muscle, this density of alpha-1 in the skeletal muscle vessels, it is the least. Understand? So it means once alpha-1 is activated by agonist, the blood vessels contraction, they have different extent in different tissues. Still remember a boy with the bear fighting a flight. That boy was so scared. Maybe his face looks pale. Remember? Because of the cutaneous blood vessels contain many alpha-1 receptor. Alpha-1 receptor induce blood vessels contraction. So maybe that boy looks pale in his face. Just because of this. Alpha-2 receptor is mainly located in presynaptic membrane. Once it is activated by norepinephrine neurotransmitter, it often induces a negative feedback in the regulation of neurotransmitter release. So once this alpha-1 is activated by norepinephrine, the epinephrine release from neuron terminal can be decreased. This is a function of alpha-2. And beta receptor, it includes 3 subtypes. Beta-1, mainly in heart and kidney. In the heart, once it is activated by epinephrine or non-epinephrine, it often induces positive effect on the heart. It means it has a stimulant effect on the heart. increased heart rate, contractility, increased cardiac output, increased AV conduction. This is a positive effect on the heart. And it also locates in kidney. Once it is activated by epinephrine, it often induces renin release. Renin release. You know, renin, it is the first substance in this RAAS. Do you know this aberration? Renin, angiotensin, aldosterone system. You know, this system in the regulation of blood pressure is very important, you know. Yeah. This is beta 1. So here, I hope you can remember this one-to-one relationship, beta 1 and heart. Once mentioned heart, you should think of beta 1. Once mentioned beta 1, you should think of heart. Understand? Okay. On the beta 2 receptor, similar to alpha 1 receptor, this beta 2 resides mostly in meniscus muscle, but its function is opposite to that of alpha 1. You know, alpha 1 in blood vessels, once it is activated, it often induces contraction. But beta 2, once it is activated by epinephrine, it often induces relaxation, you know, or other agonist. This smooth muscle, especially respiratory system, you know, trachea, this is smooth muscle in trachea, airway, or uterine, or blood vessels. You know, blood vessels, just now I mentioned, blood vessels in skeletal muscle, it has the least alpha 1 receptor. Actually, blood vessels in skeletal muscle has the highest density of beta 2 receptor. So try to think of that boy with a bear, fight of light. You know, just now I mentioned, maybe his face looks pale because of alpha 1 receptor is activated by a sympathetic nerve neurotransmitter, induce this contraction of the blood vessels in the face. But in the skeletal muscle, because of beta 2 receptor is too much, so induce this blood vessels dilation, vasodilation in the skeletal muscle. So this reaction, this response of the skeletal muscle blood vessels can increase the blood flow to the skeletal muscle. So it is very useful for this boy to flight or fight. Okay, understand? Okay, now in the respiratory system, this induce smooth muscle relaxation, so induce bronchodilation. This is opposite to the function innervated by parasympathetic nerve, you know, AM receptor, also in respiratory system, smooth muscle, you know, that AM receptor, once it is activated by acetylcholine, you know, neurotransmitters from parasympathetic nerve, it induces contraction. But this one, beta 2 in IV, it induces bronchodilation. It's opposite to parasympathetic nerve because this is innervated by sympathetic nerve. Understand? Okay, and beta 2 receptor, this is a subtype also resides in liver and pancreatic islet beta cells. You know, so it also related to metabolism. You know, increase blood glucose. Beta 3 mainly in adipose cells. You know, it also relates to metabolism. So try to remember this. remember their distribution and their function. So if you know well this content, adrenal receptor agonists and the blockers, their pharmacological effect is very easy to presume and remember. Okay, that's of this section.